Hello, Dr. Mark Johnson. Thank you for joining us today. As you know, maintaining a newborn baby's temperature within the normal temperature range, or thermoregulation as it's known, is one of the most important things that healthcare professionals can do immediately after birth. But why are preterm born babies, as opposed to full-term born babies, particularly at risk for hypothermia?
I suppose there are lots of reasons, but I think the main ones to think about are the fact that compared to, say, adults or older children, babies, particularly preterm babies, have a sort of higher body surface area compared to their weight. So they have more body surface available to lose heat, so they're more prone to losing heat. And also because they are premature and their skin isn't very well developed, it's not as thick, so it doesn't have layers of fat and other connective tissue like older children and adults do that provide insulation. So they have more space to lose heat and less things that insulate to help keep the heat in.
Okay. And babies getting cold after birth is what we most often associate with thermoregulation. However, in some cases, hyperthermia, where the baby has too high a body temperature, can also be problematic. Why is this so, and how can this happen?
Babies with very low temperatures or very high temperatures are more likely to have poor outcomes. So keeping the temperature in the normal range is one of the most important things we can do. Hyperthermia, getting too hot, often can happen because health professionals are doing everything they can to keep the temperature up. And sometimes it goes a bit too far because they're concentrating on other things. And so actually those babies can get a bit hot because of the things we do to try and keep them warm. So it's a difficult balance.
Yeah, okay. So it's like an excess of measures in this case can maybe cause too high.
I think so. I mean, sometimes if babies' mothers have high temperatures, if they have a fever or something, the babies can come out hotter than they would. But I think more often than not, they tend to be cold, and then we do things to warm them up that perhaps can sometimes go a little unchecked because we're understandably distracted with other areas of resuscitation like their airway.
Okay, so considering both of these temperature extremes, what would you say are the barriers to proper thermoregulation?
I think there are probably quite a few, and I mean, bearing in mind that I think everyone always tries to do all they can to keep the temperature up, but you know, there's lots of factors. For instance, these babies are often suddenly born without warning because mum suddenly goes into labour, and we may not be able to prepare ourselves and our resuscitation equipment in the way we would like to keep the temperature up. Labour wards and rooms and theatres are often quite drafty because of air conditioning and things, and that can be a factor. And then on top of that, you know, the babies are obviously born wet, and we need to try and keep them dry. So we need to make sure they're in plastic bags, or you know, have sides up on the incubators to keep them away from those drafts. We're trying to get to the babies to do things, and that can allow a bit of heat out. And I think, like I've already mentioned, we do all those things. Temperature control is a priority, but we've also got to worry about the baby's breathing and their circulation and other areas of resus. And sometimes we can get distracted, understandably, by those also important things, and that means temperature can get left behind or briefly forgotten about for a moment or two, that can allow the baby to get cold. And similarly, that's why they may get too hot, because we're doing all those things and get distracted about their temperature.
And I know that for some of these measures that are used to control the temperature of preterm born babies, there is varying consensus on the effectiveness of these measures. For example, on the use of humidified gases or the level of incubator humidity. What are your thoughts on this, and what measures do you think maybe merit a little bit more discussion?
That's a good question, and I'm not sure that I fully have the answer to it, because there's lots of people have done studies on various things, and actually in terms of things like humidified gases for breathing, humidity in incubators, there is some evidence for those things, but actually it's not just about temperature, it's about controlling body water as well. So that, you know, whilst we know that the best way to keep babies warm is to put them in an incubator, and that they're more likely to stay warm if that incubator is humidified. The other reason we would humidify the incubator is that because in very premature babies, their skin is very thin, they can actually lose a huge amount of water through their fluid, through their skin, through transepidermal water loss. And so having a nice humid environment reduces the amount of fluid they lose, and actually that's really important in managing them as well. So it's not just about temperature control of humidity. The same goes for breathing humidified gases. The more humid we can make their gases they breathe, the less water they will lose on their breath, and so again helps us maintain the body water as well as their temperature.
Maybe now to go back to what's considered more a basic aspect of care, which is this skin-to-skin contact between parents and baby. This is also known to have a positive impact on temperature regulation, while also being an important element of bonding between the parents and the baby. But when and why might skin-to-skin care not be possible?
So that's a really good question. And I think whilst we all know the benefits of it and want to try and do as much as we can to help bonding, there will be times, like you say, where that's not possible. And that's particularly the case for the very most extremely premature babies, or any baby that tends to be unwell or unstable, because we know that, for instance, if you're very premature, taking you out of your incubator at that time when your skin is liable to lose fluid and you're liable to lose heat, we need to be sure that that's the right time to take you out. If you're particularly unstable from a breathing point of view, we wouldn't want to necessarily risk upsetting that balance with your breathing or dislodging your breathing tube if you have one. So that may not be the right time. And equally, if you are very premature and have very fragile skin, we may want to minimise contact for those initial few days. So it will depend on a variety of factors, and different units have different policies. And some of that will be related to what those people feel is important, but also about resources. You know, you need to have enough staff and resources around to make sure that when you do take the baby out, it's safe to do so. So it will be variable, but certainly the primary focus has to be on doing what's safe for the baby and not putting them at risk and unnecessary risk.
Okay. So I'm noting from your answer as well that really this policy or practice varies a lot between neonatal intensive care units, not within countries, but also between countries as well.
I think so, and you know, I think resource, like I mentioned, is important. So it's about just having the right people around to do it. But equally, if you're in a less well-resourced setting, it may be that skin-to-skin contact is a better way of keeping babies warm, because you may not have access to incubators and things, particularly in the developing world. So it will always be a balance between the benefit you'll get from doing it and the risks of doing it, and certainly it will depend on where you live and what the resources are that are available.
Okay, I see. Okay, I think on that note we'll finish for now, but this is, I think, an important topic that merits further discussion, and we hope to talk with you again on this topic and develop it further. So thank you very much, Dr. Mark Johnson.
That's all right, thank you.